Good afternoon, everyone, and welcome to the Stanford Health Education and Awareness Charities second webinar, in which we are showcasing the work of the Evergreen Trust, HW Links, and the social prescribing offered by the Lincolnshire Community and Voluntary Service. Our first presentation is from Tim Bajitsky from HW Links.
Good.
Hello, Tim.
Okay, as Richard just said, my name is Tim Bajitsky. I'm Project Officer with a charity called Healthwatch Lincolnshire, which formed out of the original Healthwatch Lincolnshire contract, which we still deliver on behalf of Lincolnshire County Council. Next slide, please. Healthwatch Lincolnshire was founded in 2013 on the back of a couple of major health crises, one in mid-Staffordshire, where people died unnecessarily in hospital, and some of you may remember Winterbourne View, where people with learning disabilities were being abused rather than cared for, and the government, I think, they didn't want any more of that, so Healthwatch was born, and we set up, and it's a national network of, I think it was originally about 152 Healthwatch, but some subsequently on contract renewal, some have merged. Nottinghamshire, for instance, had two. They've now merged into one, and that's happened in other parts of the country as well. Here in Lincolnshire, we are, it is our sole function as a Healthwatch, whereas in other areas it may be combined with part of another that was an existing charity. I know up in Barnsley, it's Voluntary Action Barnsley, manage the Healthwatch contract, but here in Cambridgeshire and Peterborough, we are independent organisations. We have, since we've been HW Links, we have introduced a Healthwatch steering group to manage the overall day-to-day running and guidance of the work we do. So we decide what we can look at, what we will investigate, and what might not be a current priority. But obviously, we're hearing on a day-to-day basis from individual service users, patients, call them what you like, about services, some complimentary, some not so. And that sort of formulates the action that we take. Yeah, so it's and obviously we were also an information signposting service. Yeah, move on to the next slide now, Richard, please. We're a signposting service. I'll take point 2 first. Information signposting service. So all the organisations that you'll hear from today. So LCVS, part of Social Prescribing, Evergreen Care Trust, and many, many more throughout the county and beyond will feature in on our database of organisations who can support people. It's about influencing, so what people tell us gets reported back into that service provider, whether that be the Hospital Trust, ULHT, Peterborough and Cambridgeshire, what's called North West Anglia Trust that run Peterborough and Stanford hospitals, the County Council who provide social care in its various forms. All that information all the information we receive gets fed into those groups on a monthly basis, and of course the CCG. They get monthly reports. Myself as project officer, also looks at specific issues. For instance, I've just finished a big piece of work around stroke and stroke care. That's hospital care and aftercare, involving from the minute you pick up the phone to dial 999 or get taken to A&E to what happened 3, 6 and 12 months down the line. Also looking at an influencing role. Currently looking at what we call quality accounts. So all the service providers, all the hospital trusts in Lincolnshire have to do a quality account, what you or I might call an annual report. we just let, and they say what their priorities are, and report back on how they feel they've met those priorities. So we're just reviewing that alongside what people are telling us. Some of it is quite positive, and I have to stress a lot of what we get is quite positive. We don't only deal with negatives. A lot of what we get is quite positive. And so, as I said, we're just reviewing the quality accounts with a view to providing feedback as to where we are that way through the year. And hopefully, fingers crossed, just coming out of COVID. Obviously, everything that's happened in the last year has been severely impacted, as we all have been. Then we also do a watchdog role as well, which is, you know, sort of all the work we've done from the quality accounts, from the individual responses we get back from our monthly reports. We can provide a watchdog role, which we can go back 6 months, 12 months down the line and say, in 2020, you said you're going to do this. Has it happened? Or we've got evidence that it hasn't happened, so why hasn't it happened? And basically try to services they're providing. Got a small staff team. We do actually have, obviously we're working from home at the moment. We do actually have an office based in Swineshead that we use ordinarily. That might be changing, obviously, over current. If I could just work my way through it, it starts off with the board of trustees across the top, who are the volunteers of the organisation, which is what gives us the charitable status. And then you get the Healthwatch steering group below that. Then we have a small staff team, which comprises the chief executive officer, a development manager, the Healthwatch contract coordinator, the information signposting officer, an engagement officer who will go out and talk to all the groups and organisations. So if you need somebody, if you're part of a group, whether it's the one you work for or part of a group on the outside of work, and you want speakers, especially if we ever get back to face-to-face, but we can do it by Zoom if groups are still meeting, or Teams. Our engagement officer can come and give you a chat. Would have been her today, to be fair, but she's on leave. So you've dragged me across. As I say, I'm project officer, so my work is more focused on specific pieces of work. We have a project support officer who's currently working on something called the Citizens Panel, working with the CCG on the Citizens Panel. A volunteer officer who coordinates and takes great care of the volunteers. And then obviously the admin support in the office. And we've got something like, I think it's 35 active volunteers in the organisation. So the volunteer officer's got to work quite significantly, but keeps it all together quite well. So what do we mean by engagement? First of all, it's about making sure that people using health and care services and the public at large, the 80,000 people or whatever, 800,000 rather, people that live in Lincolnshire or whatever the current figure is, that making sure that people are aware of us, they know who we are, they know what we can do, and they know how we can help them. But beyond that, it's about working with others. That's other organisations, whether that's Age UK, a charity called Everyone, the Stroke Association. There's lots of condition-specific groups like diabetes organisations, Parkinson's Society, such as that. So we work with anyone and everything. We try to be creative. We're certainly meaningful. Anything we do and say, we're sincere about it, and we do really genuinely want to help. We have taken on digital engagement, obviously, as everyone else has, and it's pre-planned. So say if you've got a group, we'll go out. It might be 6 months' time, because the groups are quite well organised at planning the speakers way ahead. So it might be 6 months, 12 months ahead, where we know we're going out to talk to a group. Information, signposts and volunteers, I think I've covered on the last part. So if we move on to the next slide, please. A little bit more about information signposting. Core part of our work, as you saw on that watchdog information influencing slide earlier on. It is a core part of our work, basically. Several ways people can get in touch with us. Most obvious one, obviously, by telephone. Just pick up the phone and give us a ring and talk to you. Usually, a lady called Julie is the key person that does most of that work. But in non-COVID times, you'll see our usually volunteers, occasionally staff, out in hospital departments, doctors' surgeries, any events that might be around. If we get invited to other people's events, things like that, we will generally have somebody out there getting feedback, raising awareness, things like that. It's individuals obviously getting independent. I think the key factor for us, and one of our main reasons for being, is that we are independent. So we're not part of the, well, I guess we are part of the system because we're funded in that way. But apart from that, we are independent, and we do occasionally have to bite the hand that feeds us. So our funding comes from the county council, and occasionally we hear not so positive things about social care. So we do have to feed that information back and get the response in the same way we do for everything else. And as I said, the promotion side of it, making sure people are aware of what assistance we can provide. Next slide, please, Richard. So again, it's about getting involved, using feedback forms, using social media. Obviously, we're doing a lot more via, when I say social media, mainly Facebook and Twitter. But it does generate some feedback and results. Focus groups, usually part of my work, may involve focus groups. For instance, another example is when I was working with people with learning disabilities about annual health checks. We've got a group of people with learning disabilities together to share their experiences of health checks. Some positive, some not quite so positive. We do a lot of surveys. Again, it might be online, might be paper based. They can either way. They can be done. Paper copies are then fed back into the system, which are analysed and reports presented to the relevant parties. We use a hub system, which are the groups I've referred to earlier, where just can be just any group, a knitter and natters club, a man's shed, or something much more formal, like a Age UK group, things like that. So they get regular updates. They're asked to respond. They get information on the survey. They're asked to respond, share information. Often we've only got one contact from that group, so we're asking to share information to their group members. And of course, we're always looking to recruit volunteers from all parts of the county to enable us to do all what we do. So just a little bit of example of our current work. We did, when COVID started, on the back of a national campaign from Healthwatch England, we did a series of surveys, short, sharp surveys about how people were feeling. 1 year on, obviously different questions, because lots of worry and concerns about this new virus and being locked down for the first time ever. So questions are slightly different, but it'd be interesting to compare and contrast the results from both surveys. Watchdog, I've mentioned both stroke project and quality accounts. Citizens panel, as I say, one of my colleagues are working with CQC, and what that involves is people signing up so that CQC have got a group of people. They're looking for up to 1,000 people, so they can share their, whether it's a survey, their questions, proposed changes to CQC, in case you're not aware, Care Quality CCG Systems Plan is CCG, the people who fund all the services in Lincolnshire, so they don't necessarily provide it, but they commission most of the services, and therefore we're working with them if they're proposing closing services down, introducing new services, making changes. You can join the citizens panel and personally trying to influence what happens. CQC, of course, is the Care Quality Commission, who are doing a piece of work because we all care, looking specifically at the more vulnerable people, so people with learning disabilities, people with severe mental health problems, people with physical disabilities, people with sensory impairments, looking at those sort of groups of people, and trying to get, and to be fair to them, trying to get some positive stories. This isn't about, oh, it didn't work for me because this happened and that. It's looking at some of the positive stories, and as I said earlier, a lot of what we hear and receive is positive. So so there's a lot of work we can do around that. And then another one from the CCG, Living with a Beyond Cancer, where we've again done surveys or spoke face to face or telephone conversations with patients who've been diagnosed with cancer, gone through whatever treatments they've gone through, and are now come out the other end basically, and but still living with the fear. So that was just an example of some of the project. We obviously got far more than that going on, but just to give you a taster for the sort of things we can be involved with. Ultimately, it's anything health and social care. So it's all the hospitals in Lincolnshire and beyond. I've already mentioned Peter and Stanford hospitals, but a lot of patients from Lincolnshire go way beyond that, down to London occasionally, but regularly Nottingham, Leicester, Sheffield, depending where you live, and Grimsby if you're in the north of the county. And so our criteria basically is, if you live in Lincolnshire, tell us about the service wherever part of the country the service was. And so we have direct links into the Lincolnshire-based services, and then we'll work with the other health watchers beyond outside the county. So if you want to get in touch with us, there's an email and a website and a telephone number. And so we are still answering the phone. One thing that happened during lockdown, we've got these brand new phone systems, so even though we're on mobiles, we're all connected into each other. We can transfer calls from one to the other, so if you end up with the wrong person, a call can be transferred. So in the same way as we would if we sat at our desks in the office. So that's it from me, unless there are any questions. Thank you for listening, and I'll hand you back to Richard.
Thank you for your presentation, Tim. That was great. I'd then like to introduce to you our next presentation, which is from Lisa Gibson from the Lincolnshire Community and Voluntary Service, who is going to tell us about social prescribing. Lisa.
Hello, thank you for having me today.
Let me get your slides on up, shall I?
Don't worry about them just for a minute. I can get cracking before we get the slides. As Richard said, I'm going to talk about social prescribing. I lead on social prescribing with Lincolnshire CVS. We cover our colleagues in voluntary centre services cover kind of Lincoln and north of Lincoln into Gainsborough. So across the county, we provide one service supporting people with social prescribing, and I am going to tell you what that means in just a minute. I think first off, it's good to think about how many people in our community actually feel lonely every day. How many people literally have no one to talk to, no one to share their concerns with, no one to get excited about things with, literally no one. If I just ask you to take a minute to think about your week, the last 7 days, what kind of things you've been up to, what have you been doing, where have you been going? Now, having kind of got a picture in your mind of all of the different things that you've done, take out every single person who wouldn't have been there accept that it was their job. So anyone that you had, any friends that you had a chat with, any family members that you sat down to dinner with, all those people who just were there, and they weren't there because it was their job. And when you think about that, you start to imagine the reality that lots of people live with every day. And we know that that leads to loneliness, acute loneliness, a sense of isolation, and that's more damaging to our health than lots of the things that we think about when we think of poor health outcomes. And so loneliness is a real issue. It's very real for the people who experience it. It leads to poor health outcomes, and it actually costs the NHS a lot of money. And so now, if I could have the first slide, please. We're going to have a really quick look at why we need social prescribing. How have we ended up in such a lonely position? And then we're going to have a look at how it works in practice. So this first slide really just tells us that social prescribing, this kind of it in a nutshell, really. Social prescribing links people to things in their own communities that are good for their health and well-being, essentially. Sounds really simple, doesn't it? What's complicated about that? And why do we need to worry about things like that? So if we move on, please. So I'm going to tell you about my grandparents. Towns in the northwest of Lancashire, and used to, when we were children, tell great stories. My nan used to talk about how she'd spend all morning scrubbing the house, and in the afternoon she'd sit on her very shiny step and talk to her neighbours who were doing exactly the same thing, and they'd talk about what was going on. They'd talk about the things that worried them. They talked about, I'm sure they talked about the neighbours. They talk about, she used to talk about someone down the street whose windows weren't very clean. You know, there was that real sense of kind of, let's just all muck in the afternoon, have a brew and a chat. My granddad, he worked in a foundry, and he'd talk about the fact that although he was teetotal all of his life, he would never miss popping into the pub on the way home with all of his friends, because that's where they debriefed the day. And within that community, there was a real resilience, there was a real strength. If someone had a question, someone else on the street knew the answer. If someone ran out of something that they needed, there was always a neighbour who would be able to lend them whatever it was, whether they really had it to spare or not. It was a really resilient, tight community. Now, it wasn't utopia. There were lots of things that were wrong, but there were tremendous amounts of things that were right. So strong in professional services. So professional services weren't as trusted as friends and neighbours. And then I think it's the next slide. I've forgotten what's on my slides. 1948 came along and we got the NHS, which is just fantastic. The NHS has just been so amazing. It's really leveled that playing field. So whoever we are, whatever our profession, whatever our income, we have access to the healthcare that we need at the time that we need it. It's suppressed really devastating diseases. It's provided employment for probably hundreds of thousands of people. And there's a lot that's brilliant about the NHS. But what happened was, over time, probably over the last 50, 60 years, we've started to expert everything. We've medicalised things that used to happen quite well in our communities. And we have perhaps reached a point where there's a sense that you need a certificate for everything. You need a certificate, you need some training to be able to support your neighbours. But actually, so a lot of what the community used to do very well, the community now doesn't do, because it's lost its skills. We've lost our confidence and we've kind of experted everything. So it's kind of switched in that our confidence now in our community is low and our confidence in professionals is high. And that's why if we start to feel a bit unwell, we've learned over the last few years, we can go and talk to the pharmacist. But actually, it's taken quite a lot of convincing for some people to go and see the pharmacist, because we would really prefer to phone the GP. We would never think of knocking on the neighbour's door. So things that happened really well in our communities for a long time have now been kind of experted, and we need a certificate and a bit of training to do all kinds of things. I was a bit of a rebel when I came to have children and decided I'd quite like to have them at home. The area where we lived went into meltdown, and there was real consternation, and I understood why the professionals were worried by this prospect. But actually what had been done well in the community for generations had been so medicalised that, you know, lots of my friends, lots of professionals were saying to me, you're absolutely mad. Why would you want to have a baby in your own house, in the community, not in a hospital? I have to say, it worked very well twice. And the area that we live in now have a really strong offer for women who choose to have their babies at home. But there was a real conversation because we'd experted it so very much. So I guess what I'm saying is we've lost a bit of confidence in our communities, and we've put all of our confidence in professionals and services. And now we have a problem because we have a tsunami heading our way of mental distress. Levels of mental ill health are already very high, and COVID has not helped with that. We've also got things around the economy, so people are worried about their jobs. We've got things around political things, so people are worried about how Brexit might have an impact on contributing to a real wave of mental ill health that's coming our way. The problem is we haven't got enough experts, and remember now we're all trusting our experts. Can we make enough experts in time? The answer is no. So when we look around and we ask the question, what's strong in our community rather than what's wrong with our community, the answer is our community is what's strong. I have a theory that if we knocked on all the doors on a street and we said to everyone, can you tell me what are your concerns? What are the things that worry you? And can you also tell me what your neighbours, what you could help your neighbours with? And we made 2 lists. I think we could match those lists up pretty well. But the challenge is actually getting communities to have that conversation. And so we'll just go on to the next slide, if that's all right. That's when social prescribing comes in, because instead of having that community professional seesaw, what we try to do is we take the seesaw and put it in the corner because it's no use to anybody. We think about the person, we talk to the person, and we find out actually what's going to help them. And without question, it's always a blend of professionals and experts and people in their own community. Organisations, so it might be that they need to see their GP and perhaps there's someone in secondary care, but also that a walking group would be good for them, or a knit and natter, or horse riding, or lots of different things in their own community. What's really key is that people very rarely do well in a very isolated lifestyle, and so connecting people back into their community is really important. So if we can move on to the next slide, we're just going to think about how and the next one, that one shouldn't even be there, that was just a sneaky one. So we're going to think about how do we actually do this in practice? And the first thing that we do is we think about who might benefit most from social prescribing. So generally that's someone who wants to be active in their community and wants to access those self-help activities, because we do sometimes get asked to support people who don't want to access their community, who are quite happy with their level of engagement, and perhaps someone who really cares for them, someone who's very well-meaning, thinks that they need to get out a bit more, but actually some people don't want to get out a bit more. So it needs to be someone who's willing to and wanting to engage in their community. It needs to be someone whose medical needs are stable and managed, that's their physical and their mental health, because the last thing we want to do is kind of in a community activity which for them is not going to be sustainable, because that's almost kind of setting people up to fail. So we always want people to be able to engage in something, continue on it and really enjoy it. And people who are physically able to engage in their community. So we know that people have lots of different levels of physicality, but it needs to, ideally for social prescribing, be someone who can, if they want to join a bowls club, they need to be able to get to a bowls club and in whatever way they can engage in that activity. If they can't get out of the house, we're going to struggle to engage them in a bowls club, although we can find other things for them to do remotely. And I think COVID's helped us out massively with understanding how people can engage with activities without necessarily being in the room. So that's who benefits most from social prescribing. We don't have a kind of criteria, but those are the people who are going to get the best out of it. If we can move on. And the things that might have caused someone to become isolated, the list could be incredibly long, but we've just said someone who perhaps has a diagnosed or perceived poor mental health, people whose confidence or self-esteem has been a bit knocked, people who've been in poor physical health or bereaved, often struggle and can become isolated. And I think we all have days when we think, oh, do you know what, I can't be bothered today. Or, you know, just those days when you don't want to go out, and that's okay, actually, that's fine. It's when someone gets stuck in that and they support them. Just moving on. So we always start with this really simple question: what matters to you? We often on our referral forms get told all about what's the matter with someone, what's gone wrong for them, what their issue is, but actually what's most important to us is to know what's important to that person. You know, we can make suggestions, but it's only going to work if we're addressing the issues that are really significant to the participant that we're working with. So our first question is always what matters to you, and we COVID scuppered us a bit because we really like to ask that question over a brew, and preferably a piece of cake, because we think it's important to just connect with people in a space that's comfortable for them, often in their own home, and just have a chat, really. So let's move on. Once we know what's important to someone and what they want to achieve, we work on 3 levels. So it might be that they just want some information on an activity or an organisation, and we can signpost them to that. It might be that they're not quite sure what they want to do, but they know where they want to get to, and so we'll help them to work that out. We'll help them to set some goals, and we'll do that signposting again so they can pick that up, and then we'll check back in with them in a few weeks to see how they're getting on. Most of the people we work with don't really know what they want to achieve, and so they have no idea how they're going to get there. And even when we've helped them to work through that, they've lost that confidence, and so just giving them the information on activities wouldn't be any use. And so our link workers will go out and really facilitate that engagement. And that might be about referring them to organisations, it might be about accompanying them to different activities and organisations that they can access. So I would say most of the people that we work with are level 3, but we certainly work with people in levels 2 and 1. Okay, moving on. So the impact, because actually this is all about helping people to experience life in a much more positive way. What we hope for individuals, for participants, is that we give them an opportunity to think about and focus on the things that are important to them in a really positive way, so that their self-esteem increases, so that they feel more connected with their community. And actually, as soon as people start feeling more connected with their community, their physical and mental health often just improve anyway. And I will tell you a story in a little while to demonstrate that. For primary care, we see a reduction in GP appointments. The early research suggested there were 20% of GP appointments that were socially driven. Some more recent research suggests there's another 20% that are related to a healthcare issue that can be supported by social prescribing. An example would be someone with arthritis quite rightly needs to see their GP and possibly their consultant. But actually, if they can be referred to social prescribing and we can help them to access a yoga class, a walking group, a swimming group, to strengthen their body, then actually that will decrease their need for primary care and potentially reduce some of their prescribed medications as well. Yeah, we also see people, you know, much more equipped and confident in caring for themselves. And it's really important that people know which service to access at what time. We do sometimes start to work with people who are calling ambulances a lot. And it's largely because if you imagine being chronically ill, feeling absolutely awful day after day after day after day and having no one to talk to about it, there is a number that you can call where someone always speaks to you. And we can see how people kind of fall into the trap of using 999 as a kind of a way to get some social interaction. And we see that reduce as we work with people. And for the community, of course, there are just more people engaging in their activities and an increased number of volunteers available, because we do often work with people who go on to volunteering. So this is a case study. The case study, I think the slides are going to come out in after the thing. So I'm not going to go through that case study. I'm going to talk about a local case study for Stanford, because we worked with a lady who was really quite lonely. She'd been bereaved. She'd lost her job through COVID and was really struggling with her mental health. She'd become quite anxious and worried about being out and about. And actually, we know there are a lot of people now who are worried about re-engaging into their communities. And so for the purposes, I don't know what to call her, we'll call her Sandra for now, that's not her actual name, had previously been engaged with Mindspace, which is a brilliant mental health charity in Stanford, but she'd lost touch with Mindspace. So our link worker went back to Mindspace with her. They went and had a cup of tea and a chat. And Sonia, our link worker, asked her, you know, actually, what's important to you? What do you really want to engage with? And there were a few things. So while they were having their cup of tea at Mindspace, Sandra got a new program so that she knew what she could access there. She also talked about feeling kind of really isolated and a bit not useful. And so Sonia suggested volunteering. And they went to see about volunteering at a charity in the town, which actually didn't work out to be the right thing, but it kind of set Sandra on that way of thinking. And so they had a quick review. And Sandra now volunteers with Evergreen, who you're going to hear from next. So she's gone from feeling really lonely to actually feeling really useful as someone who's providing befriending to a person in the community who is feeling perhaps like she was at the beginning of it all. She's also engaged in some online activity with Mindspace, and she's looking forward to getting out and about. She's looking forward to enjoying some of the social connections that she's making whilst we're still in lockdown. But actually all it took from the social prescriber was a conversation around, what do you want to achieve? And let's have a look at what there is locally. We could perhaps have referred to all sorts of services for anxiety and impending depression and those kinds of things, but actually volunteering was the answer for Sandra. Can we move on one? So we are all about working together. Social prescribing, we're not a huge team. We don't provide a service as such. We don't run any organisations. We don't need any volunteers. We are only as good as what's happening in the communities around us. And we can only work with people who we're told about. So our referrals come from all over the place, from colleagues in primary and secondary care, from colleagues in mental health services. We get referrals from the fire service, from adult social care, from all over the place. And we get some people self-referring in as well. There's a really simple referral form which is available on our website, and you can always just give our coordinator a call. You'll get her number at the end of the presentation. The reason we ask for a form is because we don't have access to clinical systems like System 1 and the systems that the GPs use. So all the information we've got is what we get on that form. We don't ask for a lot. We don't, it's not a big, it's just 2 sides of A4, but it's just enough for us to be able to make an initial contact with someone. And then when we've got that information, just to get in touch with you, this is what social prescribing is about, and someone will be giving you a call in the next couple of weeks. And one of our link workers will just to do almost kind of a triage call to see, is social prescribing right for you? Did you even know you were being referred to us? Is there anything that we can do straight off? So if it's just some signposting, we can give them that information right away. And otherwise we can book in some time to start having that conversation about what's important to them. We have got obviously NHS email addresses, so the emails are secure. But if someone hasn't got a secure email address, then the information for referral can just be phoned into our coordinator, so there's no risk of anyone's information, whatever the internet is. Next slide, please. So there's our contact details. Our coordinator is in Monday to Friday, 9 to 5. Obviously our email address is there. There's my contact details there as well. We're always really happy. If you think, oh, I'm not sure if this person's right for social prescribing or not, just give us a ring and we can have a chat about that. We're always really happy to do that. I think that might be the last slide. Let's have a see. Ah, there it is, yes. So I'm just wondering if we've got any questions. Oh, we've got no questions. Either I've been really thorough or people are fed up with my voice. Any questions on social prescribing?
I'm sure you've been very thorough. Thank you, Lisa. that was really interesting. Thank you. So let's move on to the Evergreen Trust. And Julie, you are now unmuted, if you'd like to unmute. And I'll try and get your slides ready to bring up.
Thank you. Well, I'll just talk briefly whilst you're getting them ready there, Richard.
Thank you.
So my name's Julie Mayer. I'm the Registered Care Manager and I oversee the Evergreen Care Trust, Stamford District. I'm here with my colleague. We'll be sharing our presentation today to keep you amused and entertained. And my colleague here is Sue Fletcher. I thought it would be really good for us to do a duo today for your entertainment, to be able to talk about hopefully the small interventions and the differences that we make to our community. Unfortunately, we will talk about COVID a little bit because I think unfortunately it has been very prevalent, certainly over the last year, and certainly how we've adapted things here at the Evergreen Care Trust during that time. Yeah, so I think just to kind of start us off, I think obviously from our point of view here at the Evergreen Care Trust, certainly after Lisa's presentation there is one of the key things for us as well is our multidisciplinary approach. On how we interact with social prescribing, obviously the neighbourhood team, and all the other people, community nurses out there in the field. We believe that it's really, really important to have an open door ethos so that it's very easy whether you want to volunteer or whether you need part of our charity services or are paid for or are regulated services, that we are at the other end of a phone. So in the meantime, I'll just hand over to my colleague Sue and she'll discuss about our...
So Richard, if you'd like to click on to the next slide, please. Thank you very much. This is obviously a bit of history. This is the interesting bit. Well, all of it's interesting, but I love this bit. This is one woman's dream of how to help a community. So our founding CEO, Louise Marsh, in 2005 comes to Stanford area and she's in social services. So she's going out to people's houses, perhaps putting in mobility aids or putting in nursing care. Great, those people are getting the help they need. What they're finding is though that person is having nursing aid. First thing, that person is put out of bed, put into a chair. That person then at lunchtime gets additional nursing care, but they're still sat in that chair. They've had no interaction at all, no social interaction at all during that day. And there was one particular case that really struck Louise. There was a lady who was diagnosed with terminal cancer. No family, no friends. She has this diagnosis and she's going it alone. So she comes under Louise's radar, and Louise is thinking, I need to do something here. I can do something here. Louise reaches out to the churches within Stanford and says, let's start befriending. Somebody needs to walk with this lady on her particular journey. So there's one person from the churches together says, that's absolutely fine. I can befriend this lady. I can go and see her once a week, see how things pan out. I'll just be there as she needs. If she needs a friend, someone to talk to. That particular relationship then lasted for 6 years. She was able to journey with this lady, going to hospital appointments, going to doctor's appointments, and was very much there just as that friend and that support. And that's what Louise could see. This is what Louise could see that was needed. So Louise then leaves social services and starts up the Evergreen Care Trust. Louise is out there doing medical care, hydration, nutrition, medication, and she recruits volunteers to befriend, and that is the foundation, that's the growth of Evergreen, because she could see that there was one piece missing. So next slide, please. Thank you. So this is Louise, yes, going it alone with volunteers from the local churches. Sorry, Richard, next slide. So, as we've been talking about COVID, this is what we look like today. This is our a year in COVID, how we have adapted and how we've had to be flexible with the services we provide. Normally, we're providing 7 voluntary services. I think we've got about 200 volunteers, and certainly there was about 100 volunteers that came on board right at the beginning of COVID, when that was that general call to arms of people to come to help with shopping, to help with prescription collections. So what we're running today, as we are still going through COVID, is we have our advocacy services. So normally the advocates would go to people's homes to help them complete the forms. They would go to their homes to help them complete the blue badge, the mobility badge, or for attendance allowance. Our advocates, obviously, though, are working from home. They can't go into other people's homes. So what they're doing is they're providing telephone support. And our advocates, because they are the type of people that they are, if there is a query or a question and they can help, they will help. And just recently, we've had this wonderful result where a lady was being befriended and unfortunately had a diagnosis of terminal cancer. Help this lady because her cleaner wasn't going in because of COVID, but she said she was coping because she would keep one hand on the hoover and the other hand on her Zimmer frame, and that's how she could get round hoovering. So we needed to do something about this. Spoke to our advocates, and our advocates immediately turned around and said, this lady gets the upper limit of attendance allowance because she has a terminal illness diagnosis. Immediately then we can get more money in there, we can get home support in there, and that lady then is supported not only through befriending, but then also through home support. And I think this is very much the whole ethos of the Evergreen. It's not paid for services and voluntary services, it's everyone intermingles, and it's one great big sort of care circle where we support each other. So this is what our advocates are doing, and I think especially at the moment with the census, all of those letters going out to people, we've already sent a note out to all of our volunteers to say, if you have somebody that needs help, our advocates are here. They will help people with the census. And that's the thing, I think, with our advocates, they tend to sort of plug holes where there is somebody that's having befriending, but they need help with perhaps the death of their husband, and it's the life assurance policy. Can someone check that out? I'm not too sure what's happening. Comes into our advocates, they will sort it. They're wonderful people, very resourceful. I think the word, when they fill out the form, there's a box that says tenacious, and you have to tick that if you want to be an advocate. You just don't give up. You keep going. The second service that is still keep going is our chaplaincy and listening service. And I think during COVID, they've really come to the fore. We will get lots of referrals in from nurses, doctors, family members for befriending. And then what we do is we will phone that person to say, how are you getting on? I'm phoning about befriending, what did you used to do, family, and just to get a bit of a background about that person. But I think what's happening is we see, we're talking to people, and then we can put in chaplaincy or we can put in listening. And it's just that extra support. And it may be that there are people that unfortunately have gone through bereavement during COVID. And of course, they would normally go through the normal bereavement process. But during COVID, there's just these great big holes where people cannot grieve. So our chaplaincy, our phoning people once a week, and they have just to support. And I think the wonderful thing about chaplaincy is it's an interim measure. So our chaplaincy again work very closely with us so that they can easily say, right, I've helped this person, now can you put in a befriender? So that's, as I say, it's always this cyclical, just we just support each other. And then our other service, that is actually a brand new service that we started last year, is telephone befriending. Again, projects where some of the relationships are perhaps nearly 10 years old. During COVID, they have all had to stop, and it's just telephone befriending. But what we found is that we've been able to use some of these wonderful crisis volunteers that have come on board through COVID, and we've been able to match them up with people that have come to us to say, I'm not seeing anybody, I'm shielding, I haven't spoken to anybody, I don't speak to anybody from one week to the next. And we can try and match those with one of our telephone befrienders. And I think over the year we've doubled our befriending matches because we've been able to do the telephone befriending support. And what is wonderful to hear is when we go back to our telephone befrienders to do a review, how are you getting on? Is everything okay? They've said, yep, really looking forward to coming out of COVID so that I can meet up with my telephone befriender. So we're really excited about that. We've had some fantastic matches where people have just clicked. So much so that we got two ladies together, and the telephone befriender said to me, this lady lives in my sister's old house. Her brother used to work with my husband, and she's the only person that I've ever spoken to that went to my primary school. And that's that. So the telephone befriending is going on. And then what we're doing now is we're building up our foundations again, looking to relaunch the rest of our voluntary services. So Richard, if you want to click onto the next slide, please. Okay. So our other voluntary services, as I say, so we're now looking to June to relaunch the rest of our voluntary services. And they are hospital to home. So this is where somebody is being discharged from hospital, but they haven't got any family, they haven't got any support, they haven't got any friends to collect them. They haven't got anybody to say, oh, I've just got you some milk and some bread and some cheese and some ham, and I've popped those in the fridge for when you come back. They haven't got anyone to say, I put the heating on for you. So what we'll do is we'll ask one of our volunteers to go around to the house, put the heating on, get some provisions, collect that person from the hospital, take them home, sit with them, make a cup of tea, obviously, and then just stay there to make sure they're okay. And then the next day, there's another visit or another telephone call just to say, how are you getting on? Are you okay? So that's our hospital to home. We've also got a fantastic bunch of people that do our hand and nail care. I think all of our volunteers are incredibly friendly, gregarious, just energetic, wonderful people. But the hand and nail people, they are really, really lovely. And what they would normally do is they would have people that they would go into their individual homes to give them a manicure, to do their nails. And they would also collectively go into care homes. And then they would go around to perhaps 10, 15 people and be able to do. How many people can 6 people touch, physically touch in an afternoon and have a bit of a chat? So it's wonderful. And I know that I went once to a care home with a group of our hand and nail people, and we lost one of them because there was an Elvis impersonator and she wanted to go and have a dance. So she went in there, grabbed hold of one of the guys that was sat there and had a bit of a jig with him. Lovely people, absolutely lovely. But those are our hand and nail. And then we've also got our friendship clubs. So we'll be relaunching the Essex Road Friendship Lunch, which runs on a Monday and a Thursday. And then we will also relaunch, hopefully, our Morrison's Lunch Club, which runs each Tuesday down at Morrison's. We get transport, pick people up, take them to Morrison's, sit down, 30 of them, have a bit of a chat, 2-course meal, and then they can go off and do shopping. That's been running for 2 years. It would have been running for 2 years, so we ran it for a year, and then obviously during COVID we had to stop that. And then also in October of 2019 we launched our Friendship Tea, which was like a dementia support cafe, very much supporting the person with dementia and then also supporting their family. And of course during COVID that's had to fold, but really looking forward to relaunching that. That was a fantastic support, and the lovely thing was that we were doing that in connection with South Links, so they were there also. A great, because if we can collaborate, we will also always collaborate. We will also always work in partnership with other agencies. It just makes sense. And then the last one we normally do is Clean Team. So this is where a group of people would go into someone's house, spend 6 hours, 8 hours cleaning the house, because that person, it may be through illness, disability or bereavement, the house has actually just got into disarray, and it's progressed so far that they don't actually know where to start. And we can go in there and we will be very, very gracious to say, can we, should we? We won't go in there and just clean and tidy. We do work in partnership with the person whose house it is. So those are the 7 voluntary services. As I say, 3 we are still operational through COVID, and then the other 4, Julie and I are working on how to relaunch, refresh if anything's needed, but very much looking forward to that. And I know all of our volunteers are so looking forward to post-COVID, when they can go out there and do the stuff that they really like doing.
I mean, I think the key thing is as well is that, you know, just kind of coming on from what others have said today, is that we do take, you know, working in partnership with the community, with other multidisciplinary teams. But I think as well, we deal with people each day, people with mental health, people which we serve, born in the deepings and the local villages. We know that the demographics is that we know that we're all getting older, right? Unfortunately, but you know, in the Stanford area, we do know that the demographics is that the majority of people are elderly, are of older age, and therefore the thing that I think we should all be very proud of today on this Zoom webinar is that everything that we're all doing is to help that cohort of people. I mean, we're here to help everybody, but I think it is really important that, especially during COVID, that we have, you know, people have been, unfortunately, had no option, but, you know, government protocol, being told that they have to shield. And I think here at Evergreen, we have taken a very person-centered approach in making sure that the person is in the middle and everything that we do is about them. But also as well, I think what everybody will agree with today as well is that it isn't just to stop the social isolation for the, you know, the elderly, the frail, people who are struggling with mental health issues, but actually it's a dual thing. So the volunteers who actually step up and give up an hour, 2 hours, 3 hours, however much time it is a week, it's actually helping them, because it's getting them out, it's getting them to realise, because a lot of our volunteers, not all of them, but a lot of them are retired as well. So it actually gives them some time as well to be able to give back to the community, but also to feel their worth as well. So I think that's just a, you know, a key point to kind of put across as well. Can we go on to the next slide, please, Richard? So again, Sue has very well put together all about a synopsis about our 7 volunteer-led services. And I think for us over the last year as well, we've done a lot of work to ensure, and unfortunately we didn't put it in the slide, but we've actually got a new website as well. So we will get that out for everyone. But if everybody goes to www.evergreencare.org.uk, you'll be able to find there our new website, where it'll tell you all about us, all about our volunteer-led services, and also as well the fact that we're a charity first and foremost, but we're also got paid for services too. So if you could go on to the next slide, please, Richard. So as we've already said, you know, maintaining people's independence without kind of taking over, because the last thing I would want, and I know certainly years ago when I first came into the care profession, I think that what I used to do, I think I inadvertently took away people's independence because I was trying to be too helpful. So my goal when I used to, whether it would be in the hospital or whether it would be in somebody's home, it would be, you know, let me make that cup of tea for you, let me make you that dinner, let me make your bed, let me do all of these things. When actually what we hear about Evergreen is about enabling people, making sure that actually if they want to make us a cup of tea, then that's great, because we can kind of oversee them whilst they're doing these small activities in their home. And then we can also feed back to the GP if they're low in mood, or yeah, if, sorry, is that a question? Sorry, if they're obviously low in mood or anything like that. So we can feed back to the GPs, we can feed back to the community nurses, and as Lisa touched on as well, here at the Evergreen Care Trust as well, we do have the NHS emails too. So that does allow us as well to kind of have that, for want of a better term, although we're all safe, etc., how we communicate via email here, but for want of a better term, the NHS email, it's all that bit more encrypted, and it allows us to be able to share information more freely and easily across the right portals with other health professionals. So, you know, for us, again, kind of going from the birth of Evergreen in 2005, what Louise very quickly seen was the fact that social isolation was a big thing, trying to get the community, which is what everybody's talking about today. Lisa mentioned about how years ago, how everybody would know each other on the street and everybody would be kind of knocking on each other's doors and having a bit of a gossip and all of those things. And I think those times have changed. Because I know, certainly for me, you know, I do know my neighbours, and I'd be very helpful, you know, if there was a power cut or anything like that, if I thought anybody needed anything. But I know that I'm out at work most days, so therefore, you know, I maybe don't have that amount of time, especially in the winter when it's dark. So it's dark when I go to work, dark when I come home. You maybe don't have that time to be able to kind of see your neighbours on a more frequent basis as what you would have done years ago, where people would have been advocating on sitting on the doorstep. So again, what is really important is we do have our paid for services as well. So we do have our home support service, which is, it puts together all the things that people need to do to achieve to remain independent in their own homes. So again, it's not about us taking over or taking over people's decisions, but it's enabling them to remain their independence. So again, you know, our home support service is about companionship, well-being, flagging concerns to the GPs, having discussions with people so they can share their concerns. But also as well, as people do get older, or it may be that they suffer from mental health conditions, things that you and I take for granted on a day-to-day basis, being able to do the dishes, you know, being able to access the community, isn't as easy for other people. And that's where our home support workers come in. So they can assist people to access the community, assist with maintaining their home, and that can be working alongside the person, which is obviously important. Helping out with laundry, helping them with the shopping. Now, obviously, with the current restrictions, we haven't been, unless it's been an emergency, allowing people in cars, etc. But obviously, normal conditions would be that, you know, we would assist people to do, whether it be an online shop, whether it be to access the shopping together, so that they're not only having a one-to-one with that person for the day, but they're also accessing the community as well at the same time. I think the other thing as well is to be clear is that Lisa mentioned as well in her presentation about everybody needing a certificate in things these days. We do have a thorough induction programme for our volunteers and obviously for our paid for staff, because we think it is important that, but we're not pedantic about it. And I think that was the point that Lisa was getting to, that if it's your neighbour and you want to go and click the kettle on, you should be able to just go and do that. And I think for us, we have a comprehensive induction programme. And one of the key things for us as well is that with our home support volunteers and our wellbeing wardens is that we ensure that we're looking after their well-being and their resilience. Because for us, it is all about looking after the community, but we need to look after our staff and volunteers. And it is so easy to volunteer. It's so easy to sign up and be a volunteer for the Evergreen Care Trust. And because it's so easy, it is important for people to know that they are going to be looked after too. So again, as well as the home support service, next slide, Richard, we've also got our wellbeing service, which is our regulated service, regulated by the Care Quality Commission. So again, our wellbeing wardens do all of what our home support workers do, but they also oversee people's medication, nutrition and hydration. And again, this isn't about taking over, this is about enabling people to remain independent in their own home, working closely with the GPs and the pharmacies to make sure that people are getting the medication at the right time, the right dose, and obviously making sure that they have a well-balanced diet. So again, it's not about us bossing people about, but it is about us giving them as much information as possible, and whether that be accessing, like you say, the Morrison's Lunch Club, because we've done that before as well with other people, or whether that be just going to the local, not that I'm name dropping, but the local Costa Coffee or Cafe Nero, to be able to, you know, to be able to have a cup of coffee and things. And I think the key thing is as well is that by going to these people and working with Dementia Support South Links and having these cafes and allowing people to be informed of all of these different things that people are doing, it keeps the community together, and it prevents people from being stuck at home. And obviously bearing in mind the people who are stuck at home because they maybe don't have the ability to access the community because you know, they could be bedbound, etc. You know, we do have the ability for our wellbeing wardens, home support workers, or our charity-based services that we spoke about to be able to go in or to telephone these people so that they can be as connected to the community as possible. So I think, you know, I think for us here, we've really enjoyed and thank you for allowing us to talk about the Evergreen Care Trust today, and also as well been great to hear from, you know, from our colleagues as well in the community. And all I would like to say is I'm really looking forward to June the 21st, albeit well, so we can all meet up for a coffee or a pint or a glass of wine or what everybody's tipple is, to be able to celebrate being able to get together again. Thank you.
Thank you both. That was a great presentation. Have we finished the slides?
Yes, all done.
Okay, there we go. We're off the slides now. And Keith, would you like to say a word? I mean, obviously, I'd like to thank all the presenters that have presented today, and thank everyone for attending. Keith, you're...
Yeah, well, I think there's been excellent presentations. Thank you very much, Tim, Lisa, Sue, Julie. That's great. The thing is that so much goes on in the community, and it's not well known what is going on. Without the volunteering of numerous people, the NHS would not be able to survive. We are a key fundamental group to the NHS, which, you know, is forgotten, however, still perseveres with it. Within the structure, the professionals, they're looking at personalization and making delivery of services on a more related to the individual. And today has all been about looking after the individual. It's the importance that the individual can manage their condition or their age or whatever. It's, hey, I'm responsible for my health. There'll be support, but at the end of the day, it's me. And so thanks very much for the presentation. I hope everybody's enjoyed it. The next one will be on the 29th of March. We're looking at food use and misuse. Now that is from One New Lincolnshire. They have a facility that says if they've been recommended by a doctor, you can have a one-to-one mentoring on food. So we've got so in about a couple of weeks' time, we've got another event. Thank you very much. Over to you, Richard.
Thanks, Keith. Yes, that webinar is in fact a fortnight today, again at 2 o'clock. And everybody that has attended today or is attending today will get a link to register for that webinar in the email that will automatically be sent to you all tomorrow. So thanks again. We have one question that is still open from Julie from your Evergreen presentation. If you click on the Q&A button, you'll be able to see it. And you can either type an answer in, or you can actually just say what the answer is live now, whichever you prefer.
Okay, yeah. So again, just to kind of confirm, so we are the Evergreen Care Trust Stamford District. So we cover Stanford, Bourne and the Deepings, and the villages. Again, Kingscliff would probably be slightly out of our remit, but what we have said before, we have had, so for example, Peterborough wouldn't be our catchment, for want of a better term. However, we have had somebody in Wittering before. So all I would say is that if there's something that's just a little bit out of our area, we will obviously look at other and maybe try and steer people to other organisations, but we certainly wouldn't turn anybody away, is what I would say. But just to be clear, we're Stanford, Barnet, Ryle, all the little villages, Uffington, Essendine, Bourne in the Deepings.
Thank you. And Lisa, I guess that's a appropriate question to put to you as well, just for the record.
Yeah, so social prescribing with us is available to anyone whose GP is Lincolnshire. So if you're registered with the Lincolnshire GP, but equally if we get, because we often trip up with, there are so many borders around Stanford, but if we receive a referral for someone who isn't in our area, then we would point them in the right direction and get them to the right service.
Okay, so effectively the point is to just ask.
Yeah.
Okay, that's fine. That's fine. And Tim, I think you already covered that off in your presentation.
Indeed, yeah,
if you live in Lincolnshire,
you just have to live in Lincolnshire. Doesn't matter where you access your services from.
that's lovely. So again, thanks everybody for attending. We have no more questions. Thanks again to the presenters. That was all incredibly interesting, and we hope to see everybody again in a fortnight's time to talk about food use and misuse, which I'm really looking forward to, because I'm sure there's quite a few things for me to learn on that one as well. Right, okay. Thank you, everybody, and goodbye.